All right, we're back in business. We tried to make it bigger, but we were not successful this time, but we will work on it. Oh, okay. There we go. All right, a little bit into the thyroid. So we just talked about growth hormone. We're going to talk a little bit about thyroid now, specifically TSH, and then we'll move into thyroid hormones here in the next slide. But TSH, thyroid stimulating hormone, is released by our anterior pituitary as well. It's a tropic hormone, also called thyrotropin. It's produced by thyrotropic cells. All those make sense. It's going to stimulate the normal development and normal secretory activity of our thyroid, and its release is triggered upstream by TRH from the hypothalamus. So again, TRH triggers TSH, which triggers our thyroid follicles. It's going to be inhibited by rising blood levels of thyroid hormones, so normal negative feedback that acts both on the pituitary and hypothalamus. Obviously, we know when this goes wrong, we can see hypothyroidism or hyperthyroidism. And it can also be inhibited by GHIH, so a growth hormone derivative. Moving on, because we have a whole PowerPoint on thyroid, so I'm going to wait. Adrenocorticotropic hormone, ACTH, also called corticotropin, secreted by our corticotropic cells. This is nice. They all have the same name. Again, don't overcomplicate things on your NCLEX. If it is that obvious, it probably is that obvious. ACTH stimulates our adrenal cortex to release our corticosteroids. Regulation of our ACTH release is triggered by CRH, corticotropin releasing hormone, typical daily rhythm. The highest levels are in the morning, so we start kind of seeing that connection with circadian rhythm, right? And internal and external factors that can alter the release include fever, low sugar, and stress. This is an adrenal hormone. Our gonadotropins, FSH and LH, so follicle stimulating hormone and luteinizing hormone, secreted by our gonadotropic cells of the anterior pituitary. FSH is going to really stimulate our production of gametes, egg or sperm. LH is going to promote our production of gonadal hormones. So thinking about, again, estrogen, progesterone, and testosterone. LH and FSH are not occurring in pre-puberty in both boys and girls in a normal state. And it's triggered by our GnRH, and it's suppressed by negative feedback. Prolactin, secreted by prolactin cells, stimulates milk production. There is a role in males. We don't necessarily know significantly what the role in male gendered patients are. Regulation's primarily controlled by prolactin inhibiting hormone, which is dopamine. So dopamine is our main controller here. Dopamine will prevent the release of prolactin unless if it's needed. Increased estrogen levels stimulate prolactin. Blood levels rise towards the end of pregnancy, which makes sense. And local stimulation to breast tissue can stimulate prolactin release as well. Obviously, when we think about like prolactinomas, or when we think about concerns for a pituitary adenoma, we often talk about prolactin effects, breast tenderness, and one of the main treatments is dopamine agonist. You know, I had a patient recently that had a prolactinoma, and they were treated with dopamine. Ironically, they improved with Vitex. They had odd cycles. They improved with Vitex first, which also promotes dopamine in the system, which makes sense. And then we found the microadenoma. I was like, well, Vitex is not going to do it for you. We got to do more. Okay, hormone summary. This is tiny, but this is a summary slide. If you want just an easy chart to memorize, this will be your best bet. It talks about all your hormones from the anterior pituitary and posterior pituitary, what they do and where they act. If you can get this down to memory, you'll be pretty good for physio of your endocrine system outside of thyroid, which we're going to touch base on, and our adrenal system, which we're going to talk about when we do HPO, HPA axis. So we're going to combine those two together. Okay. Flying through. I love it. Love to see it. All right, the thyroid. Whew. So again, triiodothyronine, T4, or T3, thyroxine, T4. They're both iodine-containing hormones. They affect metabolic rates. This is your synthesis picture. So we're going to go through this kind of step by step just because there will be potentially some questions on thyroid hormone synthesis. So to orient you, blood, iodide, T3, T4. We have our cell here. This is from an actual thyroid gland, okay? So we have our thyroglobulin. It's synthesized and discharged. So we have our rough ER, our Golgi apparatus. It's put in these little vesicles. Our iodide then comes through. It's trapped and actively transported in. So it does have to undergo active transport. It's then converted into iodine. It's oxidized within. Your thyroglobulin is released from its vesicle, and iodine is attached to tyrosine, forming both DIT and MIT. 1 and 2, right? You can see it here. 1 iodine, 2 iodine. From there, these iodinated tyrosines are linked together to form either T3 or T4. So MIT plus DIT gives you T3, DIT plus DIT gives you T4. From there, they're endocytosed and combined into lysosomes. So this lysosome here. Lysosomal enzymes cleave T4 and T3 from thyroglobulin and allow it to be released directly into the bloodstream. This process, the main important things to understand here is iodine is involved, it's needed, it's necessary. That iodine transport is active, so there is some energy expenditure to make this process occur. And to understand DIT plus MIT, so 2 iodine versus 1. That was a question on the NCLEX in the past. T4, is it DIT plus DIT? Is it DIT plus MIT? Is it MIT plus MIT plus DIT? That was a question. I know, it sucks, but now you'll never forget it. I love those type of things. All right. So formation of thyroglobulin. So thyroid cells, again, a reminder, they're glandular cells. Thyroglobulin is made in our endoplasmic reticulum and Golgi apparatus and contains a bunch of tyrosine amino acids. Amino acids will be coming soon to you here shortly, so we'll start. That'll be fun. T4 and T3 is formed from tyrosine, remains a part of the molecule during synthesis of thyroid hormones and afterwards. Our body's really good at recycling stuff, so it tries to recycle as much as possible. Iodine is then, we take iodine and we have a conversion of iodine essentially through oxidation from iodide to iodine. We use peroxidase and hydrogen peroxide to do so. Iodine then binds with that thyroglobulin molecule. It's called organification. And then from there, you can have storage of that molecule within the thyroid gland, which is unusual for endocrine glands. So this endocrine gland, the thyroid, can actually store its thyroglobulin molecule. It doesn't just create things right when it has to use it. It does have some storage properties. It's partially why we can form things like goiters. And we can have those follicular cells get really enlarged and engorged. Because when we have an effect on our negative feedback system, we can start creating all these hormones and storing them in the thyroid and have things like hyperthyroidism, hypothyroidism, Hashimoto's, toxic goiter syndrome, etc. So it can store up to 2 to 3 months of hormone as normal. Our iodide pump. This is a sodium iodide symporter, so it traps iodine. It transports iodides from the blood into our thyroid cells or follicles, and it's going to take in 1 iodide with 2 sodium ions. So it is decreasing sodium in the blood from doing this, but not at a major rate. Energy comes from a typical sodium-potassium pump. So it does use some energy, some ATP. So sodium-potassium pump pumps sodium out of the cell in exchange for potassium into the cell, which that's what the cell likes. So then it can take sodium in with iodine. So the concentration of sodium intercellularly doesn't go up, it stays normal. Creates a concentration gradient. All right, so some quick questions. Keep our brains going. So get out your ABCDs or make one, or you can sign me your letters if you want to, whatever works. Or you could do 1, 2, 3, 4 if you want, that's fine too. So our question is, where is iodide located in the thyroid gland? Is it in the secretory vesicles inside follicular cells? the lumen of the follicle, the Golgi apparatus of parafollicular cells, or the cytoplasm of follicular cells? I'll give you a second to think and hold up your answer, your 1, 2, 3, 4, or A, B, C, or D. All right, I see some answers. I see some not committing. That's fine. It's the morning. Some people don't want to commit. That's okay. You said D. You are correct. Iodide located in the cytoplasm of our follicular cells. Iodide, right? Iodide. Cytoplasm of follicular cells. All right, we'll have more of those quick response questions for you to practice. We actually do have an endocrine game that we'll play today. So it'll be great. It's Jeopardy. All right, thyroid hormone source. So the follicles of our thyroid, 5-deiodinase converts T4, our major thyroid product, to T3 in peripheral tissue. The peripheral conversion is inhibited by steroids, beta blockers, and PTU, so medicines. Reverse T3 is inactive byproduct of peripheral conversion of T4 to T3, and it can be increased by growth hormone and glucose corticoids, so our steroids. And what are our thyroid peroxidase functions? Oxidation, organification of iodine, and coupling monoiodotyrosine to diiodotyrosine, MIT and DIT. And again, you have your equation. 2 DITs gives you a T4, a DIT plus an MIT gives you a T3. Sorry, I realized I got loud. So release of our T4 and T3 from thyroid gland, it's cleaved from that thyroglobulin molecule that was bound to. The free hormones, T3, T4, release them into circulation, which is why you can measure them both in the blood. Free hormones are the active hormones. When they're bound to protein, they're not active. They have to be free to be active in the blood. And it all is released via the help of a lysozyme. That impacts it allows it to cleave and then be released into circulation. And it goes into the blood. Once they're in the blood, T4 and T3 is bound to proteins when they're transferring. These proteins are synthesized in the liver, and it's called thyroxine binding globulin. From there, it's released slowly into tissues and cells. So they're able to go within the cell, bind to intracellular protein receptors, and be stored or used. That means their onset of action is slow and their duration is long. So when you give someone T4 or T3, you do need to wait a couple weeks to see the response. It's not going to be instantaneous. So what are some of the functions? You can think of the functions as the 7 Bs of T3, triiodothyronine. So brain maturation, bone growth, beta adrenergic effects, basal metabolic rate, blood sugar, breakdown of lipids, and babies by stimulating surfactant synthesis. So these are all of your thyroid functions. They do a lot. When in doubt, the thyroid's probably doing something, right? T3 is probably affecting something. Some of the effects on the heart are interesting. It can increase cardiac output, heart rate, stroke volume, and contractility. So there oftentimes are questions asking about thyroid, and then they'll make a connection to some part of the heart, asking if you had an increase in T3 concentration, what could you expect to happen with heart cardiac output? Or what would the response of the heart be? And then you might have options of heart rate would increase, heart rate would decrease, contraction would be stronger, contraction would be weaker, some type of list of those conditions. BMR, it's going to increase oxygen consumption, respiratory rate, body temp. It's going to increase our BMR. It's going to increase blood sugar through glycogenolysis and gluconeogenesis. Ooh, fun. What are those? We will talk about them today. And breaks down fat. So the effect of some of our thyroid functions overall then, it's going to increase transcription of genes that do those things we just talked about, the 7 Bs. Can then therefore increase cellular metabolic activity, affect growth, and then the body functions previously mentioned. In general, most thyroxine gets converted to triiodothyronine, so most T4 does get converted to T3 in the body in a healthy person, right? We're not talking about disease. This is done by removing one iodide. Those intracellular receptors have a higher affinity for T3 than T4. That is why T3 is more active, because it more readily binds. So in general, thyroid hormones are going to increase our cellular metabolic activity. Going to be from a couple different reasons. They're going to help with increasing mitochondria size and number, which mitochondria, think about the powerhouse, right, of your cell. If you have increased mitochondria and you're increasing both the size and number of mitochondria, more membrane space, you're going to be able to do more of your cellular respiration. So increased glycolysis, but really increased Krebs cycle or TCA, which is going to lead to more ATP generation, which is actually given to us through the electron transport chain. But the more surface area we have in that mitochondria, the more we can do those processes, the more energy we can generate. Because we're increasing cellular response and cellular respiration, we're going to have more heat generation in the body, because heat's a byproduct of cellular respiration. We're also going to have more ATP, so we're going to increase our enzymes of all of our ATPases, specifically those sodium-potassium pumps. So we're going to have an increased rate of sodium and potassium through our cell membranes. When we do that, we can have increased action potential because we can create that cell gradient. So you see how these things start to come together in the endocrine system. So metabolically, and this is why we are talking about biochemistry today, it's because we start talking more about metabolic stuff when we talk about the thyroid, is the thyroid function itself increases carb metabolism, so glycolysis is going to increase. We see more fat metabolism, so lipids are going to be removed from fat tissue, decreasing our fat stores in the body. We're going to also see a decreased concentration of cholesterol, phospholipids, and triglycerides from that, but an increased amount of free fatty acids. The reason is because our body, when we see an increase in thyroid hormone, we're wanting to utilize energy sources. We're not wanting to store. It takes a lot of energy to create cholesterol and phospholipids. So we go from creating storage to actually trying to utilize those food sources. So we see more fatty acid breakdown, so we see more free fatty acids because we can use that for fuel. Because we're increasing metabolic rate everywhere, we need more vitamins, more cofactors. You'll see, like I said, increased BMR, decreased body weight, and increased blood flow and cardiac output, because if we're having increased tissue metabolism, we have a greater oxygenation need. Now, this can all be normal, right? But we know if someone goes into a hyperthyroid state, if there's too much thyroid hormone being produced or being left around, we can see tachycardia, we can see weight loss, trouble with weight gain, sweating. We can start seeing all of these symptoms that are a sign of excess metabolic activity in the body. So clinically, it makes sense. When we think about what's happening internally, it represents what's happening externally. And these are all the things, whoops, that the thyroid can do to you. Whew, geez. When in doubt, it's probably doing something, right? That's why there's so many good questions on the thyroid on the NPLEX, because they can connect so many symptoms. So they might give you a question that has hypo or hyperthyroidism as a component, but it's not directly endocrine. It might be cardiovascular, or it might be GI, or it might be biochemical. So don't let it throw you. Know that there's all these interconnections and recognize what the thyroid is doing. If there's more hormone, it's going to increase metabolic rate. It's going to increase all these things. Increase heart contractility, increase cardiac output, increase GI motility. If it's suppressed or low, it's going to be the opposite. And that's a very baseline level, but you'll see that occur on the NPLEX a couple different ways. Could be either or, right? So you could have something more downstream where it's talking about if someone has a diagnosis of hyperthyroidism, or if someone has an excess amount of T4 to T3 conversion, so they have more T3 available, or it could be more upstream. If someone had maybe a blockage, they had a pituitary adenoma and were unable to release TSH, what would the effect be on cardiovascular tissue? Oh, gross. Okay, so what would that effect be? Let's think about it, right? So if we have a pituitary adenoma, we have some blockage that's releasing our pituitary cells from releasing TSH. What does TSH stimulate? T3 and T4 creation. Yep. So if we're not stimulating T4, T3 creation, if we're not able to stimulate those things, what's going to happen then to our body, to our cardiovascular system potentially? Right, you're going to have your cardiac, so everything we just talked about is going to be opposite. So instead of increased cardiac output, we're having decreased cardiac output. We're having decreased contractility. We didn't really talk about blood pressure directly, although you could maybe get there. But so you start seeing these downstream effects that are opposite. We'd have less metabolic turnover, so less production of ATP, so less energy to do all of our chemical reactions, less DNA synthesis, less protein synthesis. Right, so downstream effects could be really severe. We shut down our biochemical metabolic system, and in the extreme degree, right? What also will happen though is because we're not having TSH, we're not stimulating T3 and T4 to be created. We also then don't have that feedback loop that T3 and T4 is there. So what's the hypothalamus going to do? Keep secreting TRH. Absolutely, it's going to keep secreting TRH. So when then we have an excess of TRH, then we get an excess, then we're trying to convert to shunt to TSH, but we just have all this TRH hanging out there. And so that's when you can see those upstream effects. So the best questions I've seen on the NPLEX that involve endocrine system is when it's some type of tumor or mass or whatever blocking a pathway, and then they'll ask you an upstream or a downstream effect on a different hormone. Yes. Exactly, because you're dealing with a direct blockage or shunt that's an actual tumor or some type of congenital component that's preventing that creation, versus secondary, some type of external or exogenous factor, or idiopathic for some, or autoimmune, secondary. Yeah, good, great. So that's how I want you to think about these endocrine hormones, is be able to play in your brain. If something is blocked, what's going to be affected upstream and what's going to be affected downstream? If you can do that and kind of keep those pathways in track, you're going to be fine for the endocrine system. If you know the end organ effects of those hormones, then if something's blocked, you can know what's going to happen to that end organ effect if that hormone's not present, or if it's present in too much excess, right? And you know that without having to memorize anything. You can just logically think through those processes now, as long as you remember that picture or something that looks better than that picture. Yeah. Yeah, that's a great question. So T3, T4 effects on sexual function. So let's think about what could the body be doing to promote sexual function from T3 and T4? So if we have an increased metabolic rate, increased gene expression, increased protein transcription translation, that then itself is going to increase not just things in the metabolic system, but it's going to increase protein transcription translation everywhere, globally in the body. So if we have a decrease in that metabolic rate, we're going to have decrease in that throughout the whole system. So that's how you could see an effect on sexual function, be more decreased production of hormones in general throughout the body. Not directly related, I would say. You're not going to see a direct effect on estrogen, progesterone, testosterone from thyroid hormone. No. Yep. But you can have that effect on other endocrine glands, and that's why it's on there, right? It just keeps making these spikes. I'm not trying to do it. But that's why you're going to see effects on different endocrine glands, because you can see with your thyroid hormones, it's going to increase our DNA transcription translation potentially everywhere, globally throughout the body, more on cellular tissue that needs more metabolic need than others. But when you affect those tissues, you can affect other endocrine organs and other feedback loops and feedback control. So I do want to get to a little bit of regulation. Okay, we've talked about this somewhat. So regulation of thyroid hormone secretion. So we talked about TSH increases thyroid secretion, right? We have TSH, we're going to increase our thyroid hormones. TSH is obviously controlled by TRH, so you have that pathway. So functions of TSH. TSH can increase proteolysis of thyroglobulin. It can increase the activity of your iodide pump, so pull more iodine in. It can increase tyrosine getting iodine attached to it, that iodinization. It can increase the size and secretory activity of thyroid cells and the number. So those are all the things that are happening with TSH. So again, if we have TSH being produced, but we have some type of block that's not allowing us to produce T8, T4, or T3, we could still see increased number of thyroid cells, increased size of our glands, increased amount of iodine uptake, but we're not actually producing any products. That's where you can see things like, that's where really hypo and hyperthyroidism, secondary in particular, come into play sometimes. It's not a blockage from a tumor above, but it's an inability to convert effectively or to release those T4 and T3 hormones in the right ratios. So again, TRH, TSH, follicular cells. Negative feedback occurs. And thyroxine binding globulin binds most of the T3 and T4 in the blood. When it's bound, it's inactive. It has to be free to be active. So that's why we often would measure free T3 and free T4 in the blood, because those are active thyroid hormones. If we're measuring bound thyroid hormone, that's not active. But the majority of thyroid hormone circulating is bound. This is your basic little feedback loop we've talked about. And so there is some also secondary messengers that we're not completely free from our CMP process. This just goes through that same process we've gone through, so I'm not going to talk through it again. But essentially, cyclic ANP is triggered by TSH binding. So how does TRH regulate TSH? Talked about that a little bit. TRH secreted by that hypothalamus, acts on the anterior pituitary. TRH binds with receptors on the pituitary cell membrane. It activates a phospholipase second messenger system to then cause that release of TSH. So cold and neurogenic effects on this secretion. So some stimuli for increased TRH secretion from the hypothalamus is cold exposure, which makes sense. If our body is cold, our brain's going to want to secrete more TRH to try to get us to get more thyroid hormone, because that's going to lead to increased heat as a byproduct of metabolic processes. So that makes logical sense. When we have an increased release of TSH, you can increase your body temp by about 15 to 20%. That's pretty significant. TRH can also respond to leptin input in the paraventricular nucleus in the hypothalamus. That can help us regulate our energy balance, right? Are we hungry? Are we full? So prolonged fasting is going to decrease our plasma leptin levels. Decreased leptin then is going to inhibit TRH, therefore decreasing thyroid secretion. It's going to help our body not burn through our reserves super fast, right? Decreasing metabolic rates. We can also have excitement and anxiety that can stimulate the central nervous system, that sympathetic nervous system, which can decrease TSH secretion. Now, why would that one happen? We're sympathetically stimulated. Why would we want to decrease thyroid? Conserve energy. Okay, great. Why else? Slow metabolic rate, absolutely. Sympathetic nervous system, we don't really want to be digesting then. We want to be kind of conserving, and we're just be using the fuel that we have. Great. Sympathetic nervous system also is already going to increase our heart rate and increase our contractility. If sympathetic nervous system stimuli also increase our thyroid, we would be increasing cardiac output on both systems. So it'd be negative for our body's response, right? So the body does have some internal self-control that is smart. If we have sympathetic stimulation, we don't need to then promote thyroid stimulation of the cardiovascular system. Chronic stress can absolutely affect your thyroid. Absolutely. It can, that's why it can make someone who has Hashimoto's or hypothyroidism, if they have chronic stress that's unchecked, worse. You could maybe see a euthyroid, potentially. I've definitely seen patients that have clinically low but normal thyroid levels from chronic stress. They wouldn't be medicated, but yeah, you could see that. I would say from a clinical perspective, for the purpose of this test, you could say stress is a risk factor, or potentially could be a worsening factor for someone who has hypothyroidism. But I wouldn't go so far to say as it's a complete etiology. I'd say a risk factor. So the Wolf-Chaikoff effect, this is one of those things that you could see on the test. That's why I have it here. This is essentially thyroid's protective autoregulation system. If there's excess exposure to iodine in the body, in the system, it's going to turn off thyroid peroxidase and shut down T3, T4 production. So again, if you have an excess, we don't see this often, but you can see it. If you have an excess input of iodine into the system, it's going to shut down thyroid peroxidase, and it's going to stop T4, T3 conversion. That is why people who have been in radioactive centers have taken supplemental iodine to try to shut down that thyroid process to avoid radiation being taken up into the gland. Most common, I'd say most common cancer after a nuclear exposure is thyroid cancer. Yeah. Chemoreceptors. Chemoreceptors locally to the thyroid tissue. Yeah. Iodine concentration. Yep. So chemoreceptors, the receptors that bind iodide in the blood and take it up into the thyroid tissue, those receptors are chemoreceptors. So they'll send a nervous signal to the brain, the nervous system, saying too much iodine. We're all of our receptors are saturated, and we don't know why. It's more than our normal percentage. I think it's like 5 to 20% is typical, but all of our receptors are saturated. Then that shuts down that process. So those receptors don't uptake iodide anymore. Thyroid peroxidase won't actually bind to those iodide tissues or the iodide itself. It won't convert iodide to iodine within the cell, and therefore then T3 and T4 can't be made. Not. Then you can have buildup. Yep, in the blood. Concentration of iodide will be increased in the blood. It'll be excreted eventually through your normal processes of excretion. So kidneys, stool would be excreted over time, but it's not excreted directly from thyroid tissue if it has gotten uptaken into that tissue. But that process will stop. And if all the receptors are saturated until that blood concentration goes down, those receptors will remain saturated. No more will be able to shunt in. Once your body's concentration level has gotten to the level of acceptance, again, below that 20%, then your body will stop the Wolf-Chaikoff effect, allow normal thyroid uptake again, iodine uptake again. Yeah. But check off, I think, remember, as it turns off, right? So the Wolf-Chaikoff effect is going to turn off your iodide conversion. It's going to turn off your thyroid. There was a nuclear question at one point on the test. So if that happens, Wolf-Chaikoff, look for it. Shutting off iodine. The hyperthyroidism. It's going to increase your thyroid gland potentially with 2 to 3 times. Things that you can see: clinical conditions, clinical characteristics, high excitability, sweating, heat intolerance, weight loss, diarrhea, etc., etc. You're going to see a low TSH and an elevated free T4. Why is that? Great. Yep, exactly. You have high T4, you have poor T4, T3 conversion. T3 is what has the highest affinity to bind into those cellular tissues. You're going to have negative feedback then hitting onto your TSH, your anterior pituitary is like, oh, there's tons of T4 around. I'm going to stop producing as much TSH because I don't need it. But the body still isn't getting that conversion process to T3. Great. Hypothyroidism, though, on the other end, could be due to lack of iodine globally. Typically in the States, we don't see lack of iodine. Could be autoimmune, obviously Hashimoto's is what we see most commonly. Increased TSH, lower T4. So we typically give exogenous T4. So that's an issue with conversion of TSH and then production of T4 itself. So you can treat with T4 or T3, but most commonly we give T4, unless if the body also can't do a T4 to T3 conversion, which you can see as well. Much more common to see hypothyroidism have an issue between TSH to T4 and then be fine converting T4 to T3, but you can see both occur. All right, so some easy ones. Patients losing weight rapidly, sweating profusely, and always anxious. The patient may be suffering from what? If it is that obvious, it probably is that obvious. Yes, C. Good. You'll get a couple of those. Okay, this is your case study of the day. You are the doctor. This is going to be something we're going to work with each other. You're going to then come together in like a group of 2 or 3, discuss, and then we'll come together as a group and talk it out, okay? So this is your case. 19-year-old Krista waited impatiently as Dr. Wiseman scribbled in his chart. She hoped he was scribbling an explanation of what was wrong with her. She was tired of not feeling like herself and tired of being so stressed. She was particularly tired of how her eyes seemed to bulge outward, so much that her 10-year-old brother had started calling her bug eyes. Rude. Dr. Wiseman finally put down his pen and looked at her and said, your blood pressure and pulse are elevated. You lost weight without trying. You have difficulty sleeping. You perspire more than usual. You have continuing bouts of diarrhea. Those things combined with swelling in the front of your neck suggest that you may be suffering from more than the stress of college life. Well, thank goodness. I think we need to run some blood tests to check your thyroid function. She was shocked. He said, your thyroid secretes several hormones that have widespread and varied effects. The protrusion of your eyes is exophthalmos, pathognomonic for hyperthyroid. Exophthalmos, big bug eyes, right? You can see the whites above your eyes. It's an inflammatory response to abnormal levels of thyroid hormones. The fact that you have this condition makes me fairly certain you have a thyroid problem. All right, so now we have results. Thyroid hormone levels are elevated, but TSH is lower than it should be. Those results suggest that you probably have Graves' disease, which means that your thyroid is overactive, but we can treat it. She had lots of questions, and then he kind of offended her eyes. Okay, so answer the following. Name 2 hormones, comments. You're going to discuss this amongst yourself, answer these, and we'll come back and talk about them, okay? So you're going to name 2 hormones commonly referred to as thyroid hormone and describe their general actions. Why would an overactive thyroid cause weight loss, sweating, and elevated heart rate? We already know this one. And then how is the secretion of TSH regulated under normal conditions? So go together. We're going to take literally 90 seconds, find a partner, say your answer, try not to look at your notes, and then we'll come back. How are we doing? We ready to come back together? Yes? Okay. Who wants to take a stab at naming the two hormones commonly referred to as thyroid hormone? Call it out. Okay, what's the real name? Yes. Great. Tryptophan. Yes, absolutely. That they will list as thyroxine and triiodothyronine on your test. They won't give you T3 and T4. So no, at least be able to do the triido piece, and then you'll be fine. Good. Great. Those are both your two thyroid hormones. All right. What about why is her overactive thyroid causing those symptoms? Okay. Great, perfect. We got to get more blood through the system, so we're activating all those metabolic processes, so heart rate's going to go up. Absolutely. This one I didn't completely ask, but name the action of the thyroid stimulating hormone and what gland secretes it? It's a bonus question. Great. Yep, absolutely. Easy as that. TSH stimulates T4 to T3 from anterior pituitary. Good. And then how is TSH regulated under normal conditions? Negative feedback loop. Absolutely. Yep. Simple as that. Negative feedback loop. So T4, T3, as those are created, that's going to shoot back up to anterior pituitary. Anterior pituitary is then going to say, oh, don't need more TSH. Also, it's going to negatively feedback TRH at the hypothalamus. So both. Good. Good, good. All right. Okay. You don't get 5 points, but I was really excited earlier. I was like, we're going to have points. We're going to prizes. I didn't. So sorry. But I initially had some great thoughts. Okay. So now, same. We're going to do our little groups really fast and answer these questions. Then we'll take a break, and then we're going to come back and play an endocrine game to review. So in Graves' disease, the immune system makes antibodies that stimulate TSH receptors on the thyroid gland. What effect does this have on Krista's thyroid? Why is Krista's TSH low instead of high? Remember, she's hyperthyroid, so why is it low instead of high? If she had been diagnosed with hypothyroidism, what would happen to levels of TSH and thyroid hormone and why? And then a common treatment of Graves involves ingesting a dose of radioactive iodine, which slowly destroys the thyroid gland. Why are other tissues unaffected? Okay, take 90 seconds and we'll come back. Discuss. Are you ready to try? All right. So in Graves' disease, the immune system makes, oh wait, yes. In Graves' disease, the immune system makes antibodies that stimulate TSH receptors on the thyroid gland. What effect does this have on her thyroid? What happens in Graves? What do we know about Graves? Great, good. I love it. Okay, what else do we know about Graves' disease? Hormones are not working well. Good. Hyperthyroid, right? It's a hyperthyroid state that we're in, which is why she's seeing these effects. The antibodies made in the autoimmune condition of Graves mimic TSH. Okay. That's going to still stimulate the thyroid gland to secrete thyroid hormone, even in the absence of TSH. So with Graves' disease, we're going to see a low TSH and we're going to see an elevation in our T4. We're going to see then a hyperactive thyroid, even though we have negative feedback loop telling our anterior pituitary and our hypothalamus stop secreting TSH. So they don't. That's why TSH is low. But our body in this autoimmune condition of Graves creates an antibody that looks like TSA enough, it can mimic enough that it can still bind and create that hormone process. Okay, good. All right, so that's an important one. It's not the body that's creating TSH. That feedback loop still works, but the autoimmune condition of Graves specifically has the antibody that looks like TSH that's still combined and activate that process. So then why, yes? Okay. Can you have a goiter in Graves' disease? Yes, absolutely. Because your body is still producing more and more hormone, you can still have stimulation. And if you have a mimicry of TSH, you can still have all the effects TSH causes, right? Which is stimulation of that thyroid gland, increased follicular size, increased follicular growth, increased deposition of things within the thyroid gland. But then you're not actually getting any of that negative feedback to tell the body, hey, I don't need to do this anymore. And if the body doesn't have the need for the thyroid hormones, it could stay in here and grow and grow and grow. So you still can actually see a goiter in hyperthyroid state. It's common. I'd say it's relatively common. Absolutely. Not every patient, but it is a category of that, a clinical characteristic of that condition. Absolutely. Yeah. Good questions. Typically with Graves, you'll see a goiter or that growth that's painless, not painful. So that's would be a way that you could maybe separate it in your brain. It's not always, but most often it's painless. We already kind of talked about why the TSH is low instead of high, because her body is doing that negative feedback loop effectively. There's just an antibody that's mimicking TSH, causing her to continue to produce thyroid hormone. So then if she was diagnosed with hypothyroidism, let's say she didn't have a hyper state, let's say she had hypothyroidism, so different picture, what would that do to her TSH and thyroid hormone? What would that change? Okay, it would be inverse. So what would happen to our thyroid, to TSH? High, right? And what about thyroid hormones? Be low, great. We have low levels of our thyroid hormones, an inability of our body to do that conversion. So the body then wants more, so it increases its secretion of TSH. The thyroid gland is unable to respond to that TSH increase. So instead of actually binding and using TSH, it just continues to increase until we're able to provide exogenous feedback, right? By exogenously giving T4 or exogenously giving T3, then we can stop that feedback loop. Once the feedback loop stops, that's why the TSH gets lower. We're not correcting the problem. We're just essentially providing the negative feedback so that the anterior pituitary stops producing TSH. And then common treatment for Graves is that radioactive iodine, which destroys the thyroid gland. Why are other tissues not destroyed as well? Good, right? If it looks like a horse, it's probably a horse, yeah? Most other tissues in the body, I would say generally all, except for excretion, is not going to take up iodine into the tissue. We can excrete and get rid of iodine, but we're not actually taking it up into the tissue and using it, storing it, and binding it. The thyroid is our only organ thus far that does that on a regular basis in normal or abnormal state, is the thyroid. So giving radioactive iodine can be a relatively, quote unquote, safe. For giving something radioactive, it's not safe, but safe treatment if we're just locally trying to destroy that tissue. Good, great. Half of this battle, like I've said, is trusting what you're saying is actually going to be right? Not overthinking it. If it seems that straightforward, it probably is. Okay, all right. We are going to take, it's 9:59, it's 10 o'clock. We've made it halfway through today. We're going to take a break, so I can take a bio break. And then I'm going to get up our endocrine review game, and then we're going to move into biochemistry. Woo! I know you're excited. Okay. All right, people online, I'm going to stop the recording for a minute.